Okay. Am I audible, visible? So I'm starting the class, okay, and if any issue, just message me so that we are able to, yes, update as per that. Okay, so only, I think now it must be visible. I hope it's fine now. Now am I visible? I think now it must be visible. Now I'm visible. Okay, now I think I'm there. Okay, hello, 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 hello to everyone. Okay, so I hope you all are doing well. Yeah, so I am here again, session for you. Okay, okay, so let's start without any delay. Okay, so basically we'll be doing today and tomorrow, that is today we are having the session. Okay, and it will be a very interesting session if you people, yes, keep interacting with me so that I get a feedback from the class and everything here. Okay, so first thing is, as you all know, INI-CT is also coming. Okay, if you're giving this paper, will be sufficient to solve most of the question because it's a mix of INI-CT, older AIMS exam, then our next NEET exam. So don't have to worry at all, just attend the session and do whatever is covered, because time is the main thing here. Okay, if you use the time wisely, it will be the best possible way to prepare for the exam. Okay, so I'll directly start with the questions and the answers without delay. Okay, so as we can see, the first question is saying there is a complete heart block. Now we all know complete heart block is third degree block, and what happens here is, yes, the atria and ventricle develop their own independent beat. So that's why atria beat SA node frequency, that is 80 per minute, and ventricles, the pacemaker, become the bundle of his, which they are giving as what, 40 as a value. So they are giving it 40. Okay, so 40 per minute. So that means that is the case, but there is no relation between P and QRS. Between P and QRS. So there is no relationship which is possible between the P and QRS. So what is the result? Result is, first, let's see the options. There would be one P wave, no. Why? Because there are rather more, there is rather no P wave, which is number of equal, rather P waves are more. Okay, no P, P are more. Then inverted T, no, that is not seen. There is many seen in ischemia, etc. Okay, shortened PR, there is no PR interval, no relationship, no PR. I'll show the photo also. Let me show a photo of this phenomena. Have a look. Third degree block. Okay, so have a look at this and you will see what I was trying. So this is a complete block. If you can see, first is, in this case, first thing to observe is the P waves. So I will just color them, the P waves. Okay, the green color. So these green are the P waves. Okay, P wave, P wave, P wave, P wave, P wave, P wave, P wave. So what you see is P wave are coming at their usual intervals. Are you clear? So P waves are coming at their usual intervals. Done. So these are the usual intervals we are having for the P waves. Are you clear? For the P waves. And the RR interval are their own unique RR intervals. So you can see they are very regular, but there is no relation between P and QR. The P wave can come with the T wave also. It can come between the, yes, the R and the T. So there is no relationship. They can come anytime, which is given or possible. Okay. So that is a funda here. Okay. But one thing is there is no defect in the QRS. QRS will be normal because there is no problem in the ventricular system. So that's why it is true. So QRS would be normal. Okay. So this is the concept here. We'll go with normal QRS. Okay. And there is a independent beating of both atria and the ventricles, that is called as third degree or complete AV block. Okay. So the answer we'll take is, we'll go for D. Answer is D. Now there are two students, Vineet and Kamlesh. Let me teach this question. First question, understand what regulate our BP. Baroreceptors. So baroreceptors are for what? Regulation of BP. And how do they regulate the BP? So first question, BR. Baroreceptor. What they do? Regulate MBP. So their main BP is MBP. What is that? Mean blood pressure. And what is the funda? Baroreceptor act by negative feedback. Negative feedback. That is always decrease BP back to normal by inhibiting VMC sympathetic system. So that's why they are never going to increase. They will always decrease the BP back to the normal. Okay. Now, when do they act? The range. So the range is like this. So answer is, they have a range. What is the range? Okay, so we'll discuss that. So they act, yes, always by inhibiting. Okay. So first question is, if you destroy baroreceptor, therefore BP will increase. So destruction of baroreceptor and their nerves. Which nerve? 9th and 10th. Would increase the BP. Would increase BP. Why? Because they are inhibiting the BP. Okay. So that is why this question is right. When you destroy the baroreceptor nerve, the BP will increase because baro always decrease the BP. So question is, who is going to destroy them and how it is going to destroy? Okay. So first is, what are the range of baroreceptor action? It is 60 to 180 mmHg of MBP. So what are the ranges? 60 to 180 mmHg of MBP. Done? 60 to 180. Okay. Stand is there. Okay. So 60 to 180 is the value. Okay. Just a minute. Okay. I'll just get water and come. Just give me a minute. Cow is not there. Yeah. Now, just a second. Just a second. Chalo. Fine. Let's start. So my question is, at 60, what is the activity and 180? So activity is minimum, 180 it is maximum. So 180 it is maximum. Yeah, I am explaining all the other options also, okay? So I am giving all the options also, okay? So this question, remember I discussed all the options, why they are not right. P wave are more here, T wave is not inverted, that's mainly in ischemia, okay? And shortened PR, there's no PR possible because there's no relation between the two, and the only option is normal QRS complex. So now one cut the nerve at 85. So if you cut it 85, Barrow will stop inhibiting the BMC and the BP will increase. So BP will increase for Vineet. 65 again BP will increase. So obviously both will observe an increase in the BP. Answer will be C. Why? Because at 60, 65 the Barrow are working, and that's why if you cut the nerve between the range, the BP will increase. Are you clear now? So BP will increase. So answer is C. Now first question, this is a old AIMS question 2009, and it is a very wrong question. Why it's a wrong question? The answer is, this is the range in humans, okay, and they're asking the dog. So obviously how can you solve a dog physiology question using human physiology? Matlab, are you meaning dog and humans are same? As per some examiner they might be same, they treat us like that. So dog is same as human, so obviously no. So dog is not same as human, okay? So that is the simple funda. So they are different, so that is not true, but the answer will remain the same, okay? The Barrow will be not acting, they will cause the BP to rise up. In this case, when you cut, the BP will increase, okay? Fine. So all convinced with the answer? Human is dog. So what is the first step in this question? First step is take dog equal to human in terms of BP regulation, then solve the question, okay? Then apply the range, okay? Okay, let's move to next question. Any doubt you can ask me, okay? Anything, any doubt, any issue, just ask me. If you're not understood why the BP is increased, then baroreceptor act by decreasing the BP. So cutting them will cause a increase in the BP. They cause a negative feedback. So don't think, sir, why the BP? Because Barrow decrease the BP. Barrow are like the brake. If you cut the brake wire, what happens to car? The car will become fast. Okay, same way. If you cut the baroreceptor, that is parasympathetic, the BP will increase. Okay, so that's why increased BP occur, because they always decrease the BP. Okay, but remember, if the BP is 60, they are minimally active. 180 they are maximally active. 85 they are active. So anything which is above 60 will cause the BP to increase, because Barrow will not act. Barrow will not act. Okay, Namra? Understood? Okay. So let's move on to the next question. See, if BP is 60, you should go for still increase in BP. Why? Because even at 60, the activity is minimum. So it is 60. Okay. Yeah, if the initial BP will be less than 60, Barrow are not acting. So no effect of cutting the nerve. Okay. So below 60, no effect. Baroreceptor not acting, no effect of baroreceptor या nerve cutting. Are you clear? So I think now you understood. So that's why there is no effect. There is no electricity in the wire. If there is no electricity in the wire, what is the use of cutting the wire? Nothing. Nothing will happen. Am I clear now? So nothing will happen. Now you got everyone. I know it's a tricky question, but it is asked in the exam. You should be clear. And as you all know, I also gave the exam, NEET PG, and it was a great experience. Okay, I solved lots of questions. Okay, and yes, I was able to discuss. See, chemo work, but they are not asking cutting the chemoreceptor. They are asking cutting the baroreceptor nerve. They are not asking chemoreceptor. Yes, you are right. Below 60, chemoreceptor will try to increase the BP. Okay, right on. 40 to 60 mmHg chemo receptors work to, so 40 to 60 chemoreceptor work to, yes, increase the BP, work to maintain BP. Okay, but chemoreceptor are different, their nerve supply is different, they use separate nerve. Okay, so we can just ignore it. Okay, so let's move to next question. A 65-year-old male has a heart attack, cardiac arrest, obviously, and then it causes the following: plasma pH. So let me solve this question in a very simplistic manner. So first, as we all know, to solve the acid-base question, we should know the pH. So if the pH is less than 7.35, it is acidosis. It is acidosis, as we all know. Okay, now check the two things. Okay, if there is decreased bicarbonate, that is less than 24 milliequivalent, it is metabolic acidosis. And if there is an increased PaCO2 more than 45 mmHg, it is our respiratory acidosis. Okay, so that is the case. And if both occur together, if both, this is called as mixed acidosis. Mixed acidosis. Okay, fine. Mixed acidosis. That means if there is a low bicarb and high CO2, it's a mixed acidosis. It's a mixed acidosis. Okay. Now in metabolic, the compensation is shown by bicarb level or CO2 shown by PaCO2. So who show the compensation? PaCO2. And in respiratory, compensation shown by bicarbonate. So obviously in acidosis you will try to hyperventilate and remove the carbon dioxide. So that's why if there is a decreased PaCO2, it is, yes, it is respiratory compensation of the metabolic acidosis. It's a respiratory compensation of metabolic acidosis. Okay, but if there is a normal PaCO2, it is what? It is what? If it is a normal PaCO2, okay, I'll tell you, Devika. Okay, if it is a normal PaCO2, then what is the case? Okay, so if it's a normal, that means it's uncompensated. Okay, so it is uncompensated. So I'll just clarify the rules, don't worry. Okay, fine. Okay, okay, now here the same thing happens in respiratory acidosis. If there is a increased bicarbonate, that indicate, yes, the metabolic compensation, it's a compensated respiratory acidosis. And if there is a normal bicarb, that means it is uncompensated. Are you clear, all of you? So it is uncompensated. Okay, so this is your uncompensated condition. Okay, so summary is clear. Now last thing, if pH is normal but PaCO2 bicarb abnormal, called as fully compensated condition, fully compensated. Okay, else partially compensated. So else it is partly or partially compensated condition. Okay. So what compensated? Partially compensated condition. It is mixed. That's it. So remember a very simple rule. If you see bicarb and carbon dioxide in same direction, both are rising up or both are falling, it is what? Compensated condition. It is what condition? Compensated condition. Remember? So compensation, companion, friend, always go in same direction. Like your friend is going to jump in the well, so you also go and jump in the well, maybe not. So that's why same. But if it is opposite, remember, if you see your X coming, you should always run in the opposite direction, else your current will become your X. So remember the mnemonic, opposite is what? X. Opposite is X. Opposite is X. Okay. Opposite is X. I don't know what happened. It's coming okay from my end. So where it got stuck? Okay, I'll tell you once again from the S. If pH is normal but PaCO2 and bicarb abnormal, it is called as, yes, fully compensated condition, else it is partially compensated. Now easy method, look at bicarb and look at the PaCO2. If they are going in same direction, that is both are up and down, it's a compensated condition. But if it is opposite, it is mixed condition. And remember, companions, friend, always go in same direction. Always go in same direction. Okay. So what they go in? They go in the same direction always and always and always. Are you clear? Whereas opposite is what? Mixed. So mixed is your what direction? Opposite direction. Okay. So mixed is your opposite direction. Okay. So clear? Chalo, thank you. Now let's come to the next topic. So let's summarize and discuss. Okay. So pH, then look at the bicarbonate, then look at the PaCO2 and diagnosis. I'll give all the example. I want you to remember them perfectly fine. So I give you easy way also and the right way also. Solve with me so we never make a mistake in this topic. Okay, fine. Okay, so start. Okay, first let's say pH is low, and bicarb is also low, PaCO2 low. pH low, bicarb low, this is high. pH low, this is high, this is high. pH low, this normal, this high. pH low, this low, this normal. pH normal, this low, this low. Yeah, we'll give the PDF. I will update this later on. Okay. So let's solve this table and get this question done. Okay, please make the table. I wish you all are writing with me, because if you're not writing and just watching, you might forget. So that's why I request you to write the points also. So let's start the first. All are acidosis. Low pH, it's a acidosis. Then bicarb is low, it's a metabolic acidosis. And PaCO2 low is a respiratory alkalosis. If they are occurring in same direction, it's what? It's a metabolic or respiratory alkalosis, respiratory. So alkalosis compensates. So that's why it's a compensated condition. So it's a compensated metabolic acidosis. And the pH is less. So it's fully partially. It's partially. So it is partially compensated metabolic acidosis. Okay. Next question. Again pH is low, bicarb low. So it's again metabolic. So it's again a metabolic acidosis. But CO2 is high. It's a respiratory acidosis also. And I told you, if both are acidosis, diagnosis become mixed. So it's the opposite arrow. See the rule? Opposite. Or the rule for opposite, it is mixed. It is mixed acidosis. So it is our which acidosis? Mixed acidosis. So it is mixed acidosis. Clear? Then look at this one. pH is low, again acidosis, but bicarb is high. That's metabolic alkalosis. Metabolic alkalosis in an acidosis must be a compensatory condition. So it's a compensated condition. And again the arrows are same direction. So it's a partially compensated respiratory acidosis. So partially compensated respiratory acidosis. So let's see, if the pH is in same direction, it is compensated. I think now it's becoming easy. And if opposite, it is mix. Opposite is mix. Okay. Now let's do the other conditions. Here, low bis but CO2 high. That is respiratory acidosis. It's respiratory acidosis. But normal, so it's uncompensated. So it's uncompensated respiratory acidosis. This table solve all the question I'm telling you, okay? And finally, in this case, again it's normal, but this low. So it's metabolic. It's uncompensated metabolic acidosis. Okay, so uncompensated metabolic. Last one. Okay, pH is normal, but these two are low. That is, it is indicating a yes, fully compensated, and we are taking it metabolic acidosis because alkaloses are difficult to compensate. Fully compensated metabolic acidosis. So I hope this table is clear to all of you. Is this table clear to all of you? I'm just sending a photo in the group also so that people can understand and see. Okay. Now I'll tell you about the concept of how do you know compensation is adequate or inadequate. We use Winter's formula for compensation. Winter's formula. So Winter's formula basically give you the expected. Yes, I'll explain. Thank you for all your feedbacks, because again it's impossible to teach without feedback. Feedback is all important for regulation. Yes, I told you now. See, Shubham is asking why alkalosis. Understand, first question is, if I am suffering from, let's say, metabolic alkalosis, okay, the correction is respiratory acidosis. For that I need to stop the breathing, and you cannot stop the breathing. Why? Because as the CO2 increase and as there is acidosis, it will suffer your oxygen intake. So that is why it is difficult to correct. You can hyperventilate as much as you want. It's easy to remove the carbon dioxide, but difficult to hold the carbon dioxide. Why? Because CO2 is the main stimulus for respiration. That's why alkalosis is very difficult to compensate back to the normal. Okay, so that is why lungs can compensate acidosis, but they are not able to compensate the alkalosis because they can't accumulate the acid carbon dioxide. So that's why they can correct what almost fully. Yes, metabolic acidosis can be fully compensated, but alkalosis are very difficult or impossible to compensate. Now are you clear, Shubham? So that is why you cannot accumulate CO2. Okay. Okay, last case I told you now, if pH is normal, it is fully compensated, but these two are abnormal. That means there is a acidosis or alkalosis. I told you most likely it will be acidosis. So most likely it's a acidosis. Okay. Normal range of bicarb. Okay, normal range I am writing. Normal bicarb is 22 to 28. Some books give 26 also. Normal is 24. I am telling you. If any deviation occur from 24, try to look it properly. Okay, range is 22 to 28. Okay, and PaCO2 is 40, range is 35 to 45. Okay, 35 is the range. Okay, 35 to 45. So clear now? So clear? Let's see. So now we discuss the Winter's formula. So first is it say and give you the the value on metabolic. Again, it's for metabolic. So it give you expected CO2. Expected CO2. So give you the expected CO2, okay, for respiratory compensation. For respiratory compensation, okay. Yes, obviously I'll be coming to Vijayawada very soon. I think in April I'll have class there, okay. Yeah, I'll be taking class soon there, okay. So expected CO2, expected CO2. Now, how do you calculate? Is given as, right, it is equal to, first we take what? Bicarbonate value into 1.5. Then plus minus 8, okay, plus 8 plus minus 2. This give you the expected. This should be the expected value. Otherwise, that means it is not properly compensated. The compensation is not adequate, okay. Done now? Let me explain how. Let's take the example. Let's say the bicarbonate is 20. Yeah, let's take it. I'll let it 20 for easy, okay. And PaCO2 is, let's say, 30. So now let's check whether it's fully or not, okay. Understand. So it is acidosis with low. So both are low. Both are low. It is a metabolic compensated as acidosis. Now low. So 20 into 1.5 give you 30. Give you the 30. 30 plus 8 plus minus 2. So that is, it is 6 to 10. So that give you 36 to 40. So this is the expected value. So this is the expected value, okay. So if the value is expected and it's coming there in, that means it is compensated. That means it is if it would have been above this, that means it's not able to compensate. The compensation is not complete. Am I right now? So compensation is okay. So is it clear now? So is it getting compensated? Yes. If it would have been 42, then it will be yes. It is not compensating completely. It is rather causing a respiratory acidosis. So that means you are not able to compensate, rather we are doing respiratory. So even if it is normal value, but it is not, why? Because outside the range. It is outside the range. Am I clear now? So all of you able to understand how do you check the compensation is complete or not complete? Okay. See, Satish, is not possible. The pH can be normal, but there is what? There is opposite direction. Because if there's a bicarb increase is metabolic what? Alkalosis, and CO2 decrease is respiratory. How can two alkaloses have normal pH? So that is not possible. My telling you, it is not possible. Two alkaloses cannot be the case. Okay. Okay. See, Namra, I'm telling you very simple. If opposite direction you see, it is always going to be what? Your mixed opposite. But if one is normal, other is abnormal, that is your uncompensated. In partial, the pH will be what? Abnormal. Okay. So if pH is abnormal, that means the compensation is not complete. Okay. So just please look at this table once again. It will solve the question. Okay. Clear? Okay. Partial depend on pH. If same direction, okay, Namra, if same direction, it is compensated. And in compensated, check the pH, normal or it is low. pH is, if low, partially compensated, or if normal, it is what? If normal, it is fully compensated. Now are you clear? If opposite direction, it is what? It is your uncompensated. Sorry, mixed. I think this is a summary you should remember. Okay. So let's solve our questions. Okay. So pH is low, obviously. So it's acidosis. CO2 is high, respiratory acidosis. And bicarb is low, that is metabolic alkalosis or metabolic acidosis. No need to learn anything else, Devika. That is more than sufficient. Okay. Because there is no limit to learn. We can learn as much as possible. Okay. So this is more than sufficient. So it's what? Both acidosis. So it's a mixed. Both are going in what? Opposite directions. You can see the rule. One is going up, other is going down. So arrows are opposite. The opposite direction is the arrow. Answer is C. C is mix. C is mix. Okay. Next question. Stimulation of parasympathetic nerves can lead to complete. Yes. So what is this called? It's called as vagal attack. What is it called? As vagal attack. Vagal attack. Now remember, vagal attack spear what? Vagal attack spear ventricles. Why? Because vagus doesn't supply the ventricles. So vagus doesn't supply ventricles. So they show vagal escape. And start beating at 20 to 40 per minute, called as idioventricular rhythm. Okay. So what they are using? Idioventricular rhythm. Okay. Done. So idioventricular rhythm. So what happens? An atria will return later. Okay. So atria will start beating later on. So that means initially you will only see ventricle. Now when ventricles are beating, ventricles will depolarize and repolarize more than atria. And we know ventricular D and re will give you what? It give you QRS and T wave. And atrial D give you P wave. Give you the P wave. Okay. Clear? So it give you the P wave. So clear now? So it give you the P wave. Let's solve this question now. Very easy. First question. P wave would become larger. That occur in hypertrophy. Like P mitrale, P pulmonale. So that's not true. Fewer T wave than QRS. No, they are always equal. Wrong. Why? They are equal. Because number of depolarization are always equal to number of repolarization. Why? Because QRS must be equal to T waves. Okay, so that is not good. There would be fewer P wave than T. This is true. This is true. Why? Because ventricles are inhibited, but atria are still working. So that's why there would be fewer P wave than T wave. Clear? So there would be fewer P wave than the T waves. Okay. So fewer P waves than the T waves. Okay. So are you clear? It's true. Reason? Atria still inhibited. So less P wave, and ventricles are working, so more T wave. So less P waves. And fewer QR than, no, that's true, false. Why? Because this is two are opposite. So C and D are opposite. Fewer P wave than T wave or QRS P. So obviously fewer QRS, no. Again it is false because P are more than QRS. Here QRS more than P wave. So I think now it's clear. So answer would be C is the right answer. C is the right answer. Okay. Okay. So understand mitrale or pulmonale. Understand like this. Okay. This is, let's say, atria. Don't go by my diagram. Okay. Sir, what you are making, we can't understand. This is left ventricle, left atria. This is mitral valve. And this is right ventricle, right atria. This is our tricuspid valve. So obviously, and this is the SC node. If there is an enlargement of what? Of right atria. So what happens? The atria is much bigger. So that's why P wave become bigger. So it causes a big P wave. This call is P pulmonale because the blood is going to the lungs, pulmonary artery. P pulmonale. But if there is any problem in the mitral valve, which atria enlarge? The left atria will enlarge. If it enlarge, the current has to go to this way also. So that's why now the wave will become double peak and wide. So it's called as P mitrale. It's a wide and double peaked P wave. So let me explain. So if this is normal P wave, normal P, this will be the 2. So this is your pulmonale, P pulmonale, that is big P wave. And this is your mitrale, which is, reverse. Okay, fine. So P mitrale. So understood? So in case of pulmonale, this is the right atria enlargement, right atria enlarge, hypertrophy. And this is left atria. Clear? Yeah. So width increase in mitrale and height increase in pulmonale. So pulmonale is like mountain. It's like a mountain. Mitrale is like a double peak, M-shaped structure. Okay. So are you clear? Let me show you photo also. Have a look. So this is what I was talking about. Mitrale and pulmonale. Where is that? Look at this. So this is normal. This is which one? This is your mitrale. Can you see? This is mitrale, left atrial hypertrophy. And if this is right atrial hypertrophy, it will be P pulmonale, bigger P wave. So big P wave is P pulmonale, wide is mitrale. Are you clear now? Wide. So I hope it's clear now. So what is the answer of this question? So let's solve the question. So the answer would be obviously this. Okay. Now a person is brought RTA. Now let's understand what happens whenever there is a blood loss. There is a compensatory increase. So let's say, okay. So in case there is any blood loss, that is hypovolemic shock, compensation. Uncompensated shock. In compensated, the BP is normal, and here there is BP is low. Normal. Okay. And BP is low. Which condition? Loss more than 30%. Blood volume. Okay. Done. Now, what is the mechanism? Mechanism of compensation. Mainly, it is baroreceptors, RAS kidneys. Okay, so first RAS will cause increased water absorption. So it causes what? Increase renin, increase aldosterone, increase ADH, etc. Okay, fine. So it is the RAS system. So this is which system? This is our RAS system, renin, aldosterone, and this. Okay, now question is, I'll discuss it later, but right now that. And also increase sympathetic. Now this increased sympathetic will cause increased heart rate. That is why in shock heart rate is increased. Heart rate is a compensatory mechanism. So what do you see in the shock? Heart rate will be low or high? Heart rate will be high. In which patients? In cases of your compensatory mechanism. Are you clear? So let's see what heart rate. Increase in the heart rate is there. Okay. Then also cause vasoconstriction. Vasoconstriction. This increase peripheral resistance. And afterload. And can and increase BP and can, I'll write it later. Okay, fine. Then there's also vasoconstriction, venoconstriction, especially leg veins, to increase venous return to heart. And there are some minor mechanism also. Now, what is the end result of all? End result, okay? If they manage to increase BP to normal, it is compensated condition, else it is not fully or uncompensated. It is compensated shock. Are you clear? So it is which shock? It is our compensated shock. So it is our which shock? Compensated shock. So clear now? So it is the compensated shock. So let's solve the question first. And one more thing. Vasoconstriction, where skin, that's why skin become pale and cold. Then GIT, muscles, that's why muscles are paralyzed, and also kidneys. If kidneys, what is the result? If kidneys, it causes decreased blood flow and GFR. That's why less urine is there. So shock patient urine decrease. What is the reason? decrease renal blood flow. Okay, let's solve the question. So venous will increase, yes, it will increase. Resistance will increase, yes. GFR will decrease. Okay, so here the best answer is B. A will also increase, but remember A can fall also. There are some kind of shock, but in case of hypovolemic, return will be increased by this. Okay, so they're asking physiological response would be seen as a result. So obviously if they are saying the BP is low, that means return is not yet increased. Are you getting my point? The return is not yet increased, otherwise the BP would be normal. So that means we cannot go for increased return. Am I right now? So we'll go for the B. Reason? Yes, but increase and cause normal BP. But in this case BP is low, so we should assume, plus there is already loss caused the less return, that caused the result. So we'll go for B as the best answer. Okay, so B is the best answer. Okay, there's a loss of blood which caused the decrease in the return. You are trying to correct the return, so return is also corrected, so that's why it's the case. Okay. Okay, I'll explain. See, Samir, let me finish the question because I have a flight to Bangalore in the night. In case I will miss the question. Are you getting my point? So if I take this topic, let me do. Okay, see, I told you na, it can be right only when A and B both should be correct. A is an ambiguous question, means it could be right, could be wrong. Why? There is a blood loss. Blood loss cause decreased venous return. Okay, so blood loss, there is decreased venous return, which cause less filling of heart, less filling. EDV will decrease. If EDV decrease, it causes less stroke volume, cardiac output, BP, and BP will fall. Now are you understanding? So that's why the triggering event is the blood loss. So then compensation occur. Are you getting my point? So venous return is tried to be increased to be normal, but because it fell, this is an ambiguous statement. So I cannot go for statement A, I'll go with statement number B. Are you clear now? Fine. So return is decreased because of loss of blood. So that's why we'll go for what option? We'll go for option number B as without any doubt clear-cut answer. Okay. Okay, Samir. So these topics which are extra, I will cover because otherwise I'll not be able to finish this question. Okay. Already in 1 hour we have done just 4-5 questions. If I go at this speed, we will finish only 25 questions. So my request is let me finish the questions. Okay. In the end, I will take extra topics. Okay. Whatever. Okay. On demand topics. Okay. Okay. Let me just finish because there is some group of people who will then not appreciate that I have done extra topic. They will just say ki not finish the question. It was slow. Then I will get very negative review. So I'm requesting you these things on doubts. Like if it's possible, I will explain. But extra point, I will do it in the end so that we are able to finish the questions first. Okay. Okay. Done. And I'll do the PYQs also of this year INI-CT and the NEET PV. Now PV loop. So let me just make this PV loop and explain you. Okay, that's what I'm saying now. If I keep explaining, I will not be able to finish. Okay, let me go at a very normal speed. So first is remember in the cardiac cycle, what are the phases we are having? So we all know S1, S2. Okay, yeah, S2, S1. S1, S2 is systole. S2, S1 is diastole. It is diastole. Are you clear now? Fine. Okay. Now, first question. What is S1? Is MVTV close? And now what's that? Isovolumetric contractions. So period is isovolumetric contraction. Now, isovolumetric contraction causes what? It causes opening of the valve. So what happens? Here, the aortic valve open, aortic and pulmonary valve open, pulmonary. As they open, we start the ejection period. ejection. How much stroke volume is? 70 ml. Are you clear now? So 70 ml is your stroke volume. Okay, you eject. Okay. Once you eject, the AVPV close. AVPV close. Now you start the diastole. In the initial period, the ventricles are relaxing, so called as isovolumetric relaxation. And there is a fall in pressure. Okay, the pressure is almost zero. Pressure is zero. Okay, and now the filling will start. So what open? The MVTV open, filling start. And what occurs? Filling occur. Filling. How much? EDV, around 120 ml. Are you clear now? So this is the summary. Okay. Yes, Bharat will try to do, okay, the spatial ionized CT chanting, okay, because time is the issue. Okay. Okay. So isovolumetric relaxation, pressure is zero, MVTV open, filling. What is the volume? 120 to 130 ml is the filling. Okay. And is it clear to all of you? So now I'll make a graph of this thing in the same manner. Please have a look. So this is a graph. This is stroke volume. Sorry. This is pressure. This is volume. Start. Here. 50 ml is the volume. 50 ml is the volume. And pressure is zero. If you remember, I told you at zero pressure, there's an opening of a valve. Which valve open? Obviously, the MVTV open. So here at point A, MVTV open. I'll just write MV open. The moment MV open, the volume start to increase and reach a volume up to B, which is 120 ml. What is B? 120 ml. And this is your filling phase. So what is volume V? So B is EDV. So it is our EDV. Okay. Yeah. Any extra topic? Okay, Namra, I'll take in the end. Don't worry. Let me just finish the questions first. Okay. And we will discuss. 120. So what is the filling? From 50 ml, you fill till 120 ml. Now at B, what happens? The MV closes. S1 sound. And now the pressure will climb up. The pressure shoots up. This pressure increase till point C. This is isovolumetric contraction. Pressure is increasing, but volume is same. That is the case. At C, the aortic valve open. Once it open, the volume goes out. So volume is ejected. So this is ejection phase. How much? Stroke volume 70 ml. After ejection, the volume decrease. And this is point number D. At D, the aortic valve closes. S2. And the volume is 50 ml. This is called as ESV, and systolic volume. So and systolic volume is 50. And now the pressure will fall, but volume remain the same. This is called as isovolumetric relaxation. So isovolumetric relaxation. Fine. So isovolumetric relaxation is the case. So are you clear? So isovolumetric relaxation. Now comes the question. What else do we also see, discuss, or have? Okay. So in this graph, what is AB? Filling. So that's why I'll write like this. BCD is systole. And who is diastole? It is DAB is diastole. So I think now clear? Very easy. So this is the summary. So isovolumetric contraction ejection is systole. Isovolumetric relaxation filling is diastole. Okay. This diagram shows the same things. Okay. Perfect. Okay. Now let's do the questions based on this. So what is the filling given by AB? Filling is AB. Isovolumetric BC. So that's why what is end diastolic volume given by? Obviously point number B. What are the volume where the systole ejections are? C. And the volume ejected is, you can do 120 minus 50, 70 ml. So that's why how do you get that? SV is EDV minus ESV. That give you the value. Done. So solve. So where is EDV? So this is ESV. This is EDV. And this is stroke volume. You can take these points. This is stroke volume. So stroke volume is from here to here. Rather, I should make it. This is stroke volume. I hope everything is perfect. Okay. So answer would be B. And what is ESV given by? D or A, both are ESV. Next question. A 70-year-old male presents to ED with sudden onset. ECG shown. Really sorry. The ST changes are seen. Which changes? ST elevation changes. So start the diagnosis. First is remember, look at this diagram and try to remember the leads. Okay. So this diagram, I always tell the people, it's very important, help you solve question. Please take a screenshot and remember. First, aorta is giving branches. What are the branches? Two branches, right and the left coronary. It is right. Okay, Khans is right, but understand, when does filling complete? It is at point number B. The filling is complete. Isovolumetric is same. But point is, we should not take at the end of isovolumetric. Why? Because ejection start at the end of iso. So C is not a good indicator. It can shift. Understand? Na? This point C, it is at. So it can be here also, here also, here. So at C, divergence start. So you are not sure about C. C is the point we are changed. So better we go with B, because at B filling is over. So where you start going upward, that is the B. Am I right now? Done? Okay. Now, remember, the right coronary artery supply the inferior wall of the heart. So, supply which wall? Inferior wall of the heart, which is mainly right ventricle. And the ECG leads are AVF 2-3. AVF 2-3 are the inferior wall. Then the left coronary has two branches. Circumflex, which supply the lateral wall, left ventricle. Leads are AVL and 1. AVL and 1. V5, V6 are also included. Whereas left anterior descending supply the anterior wall, which is V1 to V6. V1 to V6. Okay. And in case of V1 to V6, septal are V1, V2, anterior leads are V3, V4, lateral are V5, V6. So if there is a V1 to V4, it is anteroseptal. V3, V4, V5, V6 is anterolateral. If V1 to V6 is called as anterior wall infarct MI. Okay, done. So these are the leads, don't forget. Okay, and I made a mnemonic: inferior. If someone fail exam, feel very inferior to others and give second, third attempt. So remember, failure, second, third attempt, inferiority complex. So mnemonic was failure, fail F, will give second or third attempt. I know it's a very negative mnemonic, but exam is more important than mnemonics. Okay, so that is the mnemonic. Okay, and what are the earliest changes? So earliest changes in the MI are what? They are, yes, tall T wave and then ST elevation. So tall T wave and the ST elevation. Okay, so that are the changes. Okay, so you can see the evolution. So this ST elevation, tall T wave, then pathological Q wave, and then ultimately biphasic with T wave inversion. Okay, so my question here is, if it is a inferior wall MI, where will you see ST changes? We'll see in the lead 2, 3 and F. And remember, reciprocal leads. Anterior is opposite to posterior and lateral is opposite to our, yes, inferior. Now what is inferior leads? 2, 3, AVF. For the lateral leads, AVL and 1. So that's why if you see ST elevation here, we will show ST depression. So this was the question asked in the recent, NEET PG exam 2019. What will be the reciprocal changes seen in? So in inferior, changes will be AVL and 1. Let's see that. Okay. So in this diagram also, if you see clearly, there's the elevation. I'll just keep writing elevation, elevation in 2 and 3. And L show a depression. Can you see a depression? Is going downward. And lead number 1 is also showing a, yes, depression. Lead 1 is also showing a depression. You can see it's going down. So depression is seen in AVL and 1. Elevation is in F also. V1, V2 are normal. They are the normal ones. They are normal. They are normal. No elevation. Okay. So they are normal. So that's why it's a classical anterior wall MI. Sorry, inferior wall MI. Okay, it's an inferior wall MI. Why? 2, 3 and AVF show the elevation and 1 and L is showing the depression. Are you clear? Anterior wall will be V1 to V6. Pericarditis is just ST changes. Okay, clear, but doesn't show any lead specification much. Posterior wall you cannot see. For that we need V7, 8 and 9 leads which are not given. Okay, done. Okay, question number 8, which is not a measure of stroke. We've done that question just now. Okay, if you remember, EDV minus ESV. Yes, stroke volume is EDV minus ESV. True, it is right. So it is right, true. So true statement. It is right. Ejection fraction time. Now what is ejection fraction? We all know ejection fraction is stroke volume by EDV. So the stroke volume by EDV is our which fraction? Ejection fraction. Okay. Yeah, I will share the PDF of this in the end. Don't worry. Okay. Okay, but still write something of your own also. Okay. So it is stroke volume by EDV. So if you multiply ejection fraction with this, what do you get? Sorry. So EF into EDV. What is the formula? What is EF? Stroke volume by EDV. They cancel either. What is left? Stroke volume. So this is right. This is also right. It will give you stroke volume. It is also true. Then ejection fraction time cardiac output. Let's do that. EF into cardiac output. That is stroke volume by EDV into stroke volume into heart rate. Because for the formula, it is stroke volume into heart rate. So that will give you which value? Stroke volume square into heart rate by EDV. What is this? ये क्या बवासीर बना दियो? ये क्या है भाई? I've never seen this formula. What is this? This is not correct. So this is the answer C. And cardiac output is what? Stroke volume by heart rate. Sorry, into heart rate. So they're asking, yes, cardiac output by heart rate. That will be stroke volume into heart rate by heart rate. So heart rate cancel. What is left? Stroke volume. So this is also true. So all these are true. So answer become B. Sorry, answer becomes C. Okay. So answer would be C. Done. So answer is C. Okay. Now we see which shock the central venous pressure is increased. Let's first see what is the CVP. How does it occur? What are the mechanism? So first understand CVP indicate venous return. Okay, CVP indicate venous return, that is blood coming to the heart. Okay, now what are the types of shock? I will explain in the easiest manner, so you don't have to worry at all. Okay, understand, there are two main categories of shock. One is related to heart, others distributive. Okay, so one is related to heart. Okay, that is less cardiac output because of this. Okay, so remember, hypovolemic shock, there is less volume and all pressure volume low, all pressure low, all pressure, less volume and all pressure are low. There is a simple rule, JVP, BP, CVP all are low. Why? Because there's less volume, everything is low. Okay, done. One line summary, less volume, everything is less. Okay, then but heart rate is more. Okay, but heart rate more. Then come cardiogenic shock. Here heart failed to pump the blood, so heart is failing to pump the blood. If heart failed to pump the blood, obviously what happened? If heart failed to pump the blood, yes, again BP decrease. But as blood accumulate, it can cause, yes, cardiomegaly, congestion, pulmonary or systemic edema, and cause a increase in the pressure and cause increase JVP, CVP, PC, WP, etc. So that's why it is the, yes, it is a shock with increased pressure. So what shock pressures are increased? It is our cardiogenic shock, cardiogenic shock. Okay. Then come a very, very important, that is neurogenic shock. Here decrease sympathetic is there, decrease sympathetic. Okay, example spinal surgery, very common, spinal surgery or injury or even anesthesia, very commonly, because sympathetic nerves are coming from the spinal cord, remember, thoracolumbar. So that's why any damage to the spinal cord decrease the sympathetic, that cause, and because of decreased sympathetic it will have, so it will be decreased heart rate, decreased output, decreased BP, blood accumulate in the vessel. Okay, neurogenic shock. So again what happens here, the, yes, I'll find the values will decrease, again values are decreased, so again decrease value, so decrease return and blood accumulate in vessels. Why? Because of, due to vasodilation, due to vasodilation. So what causes vasoconstriction? Sympathetic, and that's why blood will accumulate in the vessels. Now blood accumulation in vessels, it causes, yes, decrease venous return, decrease venous return. Okay, decrease JVP, CVP, all will decrease. So it behave like that. Okay, but because the blood accumulate in vessels, okay, and there is a vasodilation, it is called as warm shock. Warm shock, it is called as a warm shock. Why warm shock? Because the blood is there in the vessels in the body, so called as a warm shock. Are you clear? Warm shock. So what shock you have? And these are the cold shock. These two are cold shock because there is less. Okay, these are the cold shocks. Okay, cold shocks. Now other examples of warm shocks. So other example, so these warm shocks or this, okay, so all these are together called as distributive shock. Distributive shock. What happens? Volume is normal, unlike hypovolemic. Volume is normal but wrong distribution. What is the meaning of wrong? That is accumulate in vessels. So blood accumulate. Blood accumulate. Example, neurogenic, then anaphylactic. Anaphylactic. Here histamine causes the vasodilation. Histamine cause vasodilation. Are you clear? So it's same as neurogenic, but here is the histamine which cause the vasodilation allergic condition. Are you clear? And both are warm shock. Now someone says about septic shock. Septic is basically neuro plus cardio. Neuro plus cardio. Okay, why? First, why neuro? Because it causes vasodilation, or rather distributive plus this, better word, distributive, distri plus, so it's distributive plus cardio. Why? Because the bacterial toxin inhibit the heart. Toxins inhibit the heart. So bacterial toxins will shut down or inhibit the heart. So which toxins? Bacterial toxins will inhibit the heart. Okay. And why distributive? Again, the endotoxins, bacterial toxins, again cause vasodilation. So that is the summary. Okay. And if vagus is increased, it's vasovagal. Vagal shock. Now in these two, there is a decreased heart rate. Decreased heart rate, but here fever can also be seen. Okay. So I think this cover everything. Okay. All the shocks. See, obstructive shock is a type of cardiogenic mostly. Reason, heart is not able to pump. So that's why obstructive, again, cardiogenic features will be seen. Okay. So obstructive shock show similar features. Okay. So that's why again the CVP will increase. Okay. So what are the answer of this question? Which shock CVP is increase? Obviously septic, it will decrease. Cardio increase. Distributive decrease. Hypo decrease. So answer is B. Clear? So I explain all the shocks. Now, which of the following is not true for cardiac? Now, understand first thing. All cardiac fiber should contract as one unit. So, all fiber contract together. But skeletal muscle, we should be able to move different fibers. So, that's why skeletal muscle show graded contraction. Cardiac show all or none. Sorry. Due to gap junctions, the heart and and visceral so once again, so due to gap junctions, heart and visceral smooth muscles. Which ones? Heart and visceral. Like example, uterus, bladder, GIT. All fibers are connected as single unit. Are you clear? Are connected as single unit, connected and contract together. And that's why also called as syncytium. Syncytium. Okay, neurons have electrical synapses which use gap junction, but they are not a syncytium. Different neurons can fire different time, so they are not a syncytium. Are you clear? So remember, heart and smooth muscle are a syncytium, but skeletal muscle are multi-unit. Okay, skeletal muscles, they have multiple units, so they can do complex movement. So you can activate 1 unit, 2 unit, 10. So that's why they show differential activation, not single unit. Okay, fine. Now So this is the first statement which is not true. Okay, so this is wrong statement. Okay, so this is wrong. Excitation both. Now remember, smooth muscle don't have SR. No SR, sarcoplasmic. So calcium for contraction from ECF, MCQ. But skeletal and cardiac muscles have SR. What is SR? Sarcoplasmic reticulum. So what do they have? They have a SR. What is the SR? Sarcoplasmic reticulum. If they are having the SR, that means their calcium for contraction for excitation contraction coupling from ICF only, from ICF. So which muscle can use their own calcium? Skeletal and cardiac. Which depend on outside calcium? It is our smooth muscles. Okay. Also we know cardiac AP has the phenomena, right? So this is true. This is true. This is false. Then question number C. Excitation coupling is not dependent on extracellular. True. Again true. Why? They have SR calcium. And APS plateau, yes, it is true. So what is the reason? I will make you and I will write down. So it is also true. Okay. So let's see the cardiac AP. So cardiac AP basically has multiple parts. What are they? This is phase 0. Depolarization. This is phase 1. Early repolation. This is phase 2 plateau. That is the plateau phase. So phase 2 is the plateau phase. Okay. This is phase 3. That is our late repolation. And this is phase 4 RMP. Now the purpose of phase 2 plateau is basically, this was again this year INI-CT exam or this NEET PD question. So they gave this graph and the answer was phase 2. Phase 2 is by calcium L channels. Calcium L channels cause the phase 2 calcium L channels. Okay. Clear? So calcium L channels. And what are the benefit? It increases refractory period and prevent arrhythmia. So what increase the refractory period? It is calcium L channels which increase our refractory period. Are you clear? So refractory period is the case. Done? So let's solve the question. It is also true. So answer is question number 10. Answer is B. Sorry, answer is A. I'm really bad at remembering what was the question asking. Is asking not true. So answer is A. It is not true. Skeletal show what? Graded, but cardiac show syncytium. Question number 11. They are saying arterial blood oxygen. So let me just teach the answer here. So answer is, what are the formula for oxygen supply or consumption? So oxygen supply per minute is given as cardiac output into arteriovenous oxygen difference. Arteriovenous oxygen difference. Okay. Fine. So what difference? Arteriovenous oxygen difference. Okay. Now if you write the values, okay, how much is the oxygen supply they are giving? Let me check. It is given to be around 4 liter per minute. Cardiac output they have not given, and artery they are mentioning 19 per 100 minus 3 per 100. Am I right? Now let's solve. 4 liter per minute is cardiac output into 16 by 100. So when you reverse it, it goes like this. 4 liter per minute into, it goes here, so 100 will give you cardiac output. Okay. Now when you solve, what happens? It gives 4, and 4 when you cancel here, it gives 25. So total value become cardiac output is 25 liter per minute. Understood? So 25 liter per minute is the output we will see or we will have. Okay. Clear? So clear now? So it is the output. Fine. So 25 liter per minute. Now what is the formula of cardiac output? Stroke volume into heart rate. So what is stroke volume? It is cardiac output by heart rate. So they gave the heart rate is 180 per minute. 180 by 25 liter is 25 ml. So it will give you around 138.3 ml per minute. 138. If you don't trust me, I'll do it on calculator. Some people don't trust how I got this. Let me write. So 25000 divide by 180. 1.388888. 38. So that is the answer. Now you got the idea. So I hope I am able to explain it to you properly. So 1388888 is the value. So clear now? So clear now? All agree? So what become the only possible and the right answer? Tell me. So the only possible and the right answer will be how much or which one? So let's see that. Okay. So this is wrong, this is right, wrong, this is wrong. It is 138. So answer is B. Are you clear? So answer would be B in this case. Okay. Okay. Now we see question number 12. Now before 12, I need to explain you what are the flow volume curve, what is restriction, what is obstruction. So let's start with that. Okay. So first understand, if there is obstruction of airway, it is obstructive, obviously we know, and restrictive is there is decreased compliance. So all volumes are less. So one rule is what? Okay. First, RLD. What is RLD? Restrictive. All volumes and capacities are poor. That's one rule due to poor compliance. So the funda, due to poor compliance is the case. So which compliance? Poor compliance. Everything is poor, or we can say everything is less. Am I clear now? So why is everything poor or less? Answer is, reason is clearance is the concept. So the concept is clearance. Okay. Now obstruction. Now obstructions could be of various type. It could be either a fixed obstruction or a variable obstruction. Now what do you understand by fixed or variable? Let me explain it in a simplistic manner. Right? So question is, if I say fixed, that means the obstruction is in such a manner it doesn't change in inspiration, expiration. Both inspiration, expiration are poor. So both inspiration and expiration are poor. So both inspiration and expiration are very, very, very poor. Are you clear? So what is poor? Inspiration, expiration, both are poor. Both are very, very, very poor in this case. Are you clear? So both are poor. Okay. Example, complete obstruction of bronchus. If one bronchus is completely blocked, like a tumor of foreign body, no air can come, no air can go. So that's why it will be a complete obstruction, and there will be, yes, 50% decrease in inspiration, also 50% expiration. So both are reduced. So what is reduced? One or both? Both are severely reduced in this case. Are you clear? Done? Next question. What is variable? Here one phase is affected more. One phase affected more. Which phase? If inspiration is poor relative to expiration, it is extra thoracic obstruction, called as VETO. Variable extra thoracic obstruction. Are you clear? So variable extra thoracic obstruction. Okay. If expiration is poor, then it is VITO. What is that? Variable intrathoracic obstruction. Variable intra. Now why so, what so? I'll explain. Understand. They are above sternal notch. Above sternal notch. So they are above the sternal notch. Clear? And they are below the notch. Example, asthma, COPD, okay. So asthma, COPD are the examples. Fine. So asthma and COPD. Here example, okay. Okay, it would be tracheomalacia, or yes, glottic stenosis, supraglottic, or diphtheria. Even this came in this year NEET PG exam. They gave this yes, LTB, there's acute laryngotracheo bronchitis, in with this steeple sign is seen. So that's why it is your obstruction. Now you will say, sir, but why is this so? Let me explain with the diagram. Understand, this is your thorax. This is thorax. and these are the airway. Outside thorax, inside thorax. These are intrathoracic. So these are intra, these are extra. This sternal notch. So now what happens is, if there is an intrathoracic obstruction, during expiration, the high pressure of the thorax compress the airway and cause more narrowing. So by expiration, the compression of thorax by muscles will further narrow airways. Example, wheezing. So that's why wheezing is the hallmark of this obstruction. So wheezing is the hallmark. Okay. So what is the main hallmark? Answer is wheezing is the main hallmark in this case. Okay. So wheezing is the main hallmark. Okay. Done. So wheezing is the main. But if there is a intrathoracic obstruction, when the person inspires, the air is pulled into the airway. If there is any inflammation, some polyp, etc., as you inspire, it will pull the tissue inside the lung. As it pull into the lung, the airway get narrow. The airway will become narrow in this case. So what will cause the narrowing? Yes, pulling of the structure inside will cause the narrowing. Is it clear now? So what happens here? Number I told you, obstruction is fixed if it doesn't change much in inspiration and expiration. Okay, clear? If there's a goiter which is compressing trachea, it is most going to be a variable extrathoracic obstruction. Alright? Okay. Here, so here what happens? In inspiration, soft tissue are pulled into the airway, narrowing the airway. So soft tissue are pulled into airways. As they are pulled into airways, what the result? The airway becomes same or narrowed? The airways will become narrowed. Are you clear? So airways will become narrowed in this case. Are you clear? So as the airways become narrowed, what happens? Obviously, it will lead to what? A decrease in the airflow, and that cause more obstruction. Okay. And in inspiration, expiration, as you cough out, the soft tissue are pushed out, and airway become wider as you go out. So that's why coming in is a problem, but going out is not a problem. So pulled into airways in inspiration, and that's why stridor is the main sound here. So if you hear stridor, what is the diagnosis? It is which obstruction? Intra, extra. Stridor is mostly, yes, intrathoracic or extra? Extrathoracic obstruction. So that is the case. So what are the mnemonic I make? In ka I ka in. So remember, in ka I ka in. So in case of which obstruction? In case of intrathoracic obstruction, intra-obstruction, expiration poor. In case of extra obstruction, inspiration is poor. So how to remember? Yes. Intra obstruction, expiration, extra obstruction. So I in I. Okay. So remember, X is in is X. एक ही बात है, सही है? तो याद करना, इन को X मतलब अंदर लाओ X को, या फिर X के अंदर जाओ, जो भी है, ठीक है? So इनका X, okay. Yeah. If there is inflammation or any obstruction of the upper airway, the extrathoracic airway, as you inspire, it will pull soft tissue into the lumen, narrow the airway, and problem is increased. In expiration, high pressure force the airway out, clean the airway, and problem is solved. So problem is solved. So that is the concept here. Okay. Okay. So are you clear? Okay. Now, how do you diagnose? One is we can make flow volume curve. So write down flow volume curves, spirometer. Flow volume curves. Okay, let's see. Actually, we lost half an hour in the beginning because of again delay, technical issue. But don't worry, we'll compensate that. I'll take class 15-20 minutes extra so that we are able to cover. Then I have to go to airport running to catch the flight. So very hectic time. But again, we'll be able to manage everything. Don't worry at all. Okay. Now this is our flow rates. We are on track. We have covered 11 questions, 1 hour. Okay. So we are on track. Okay. So this is flow rate and this is volume. This is the volume. Okay. Now this is 0. This is 5. This is 10, 15 plus. This is minus 5, minus 10. Now first flow rate is liter per second. Now what do you mean by flow rate plus minus? Plus is basically upper half is expiration, below half is inspiration. Reason, when we people, I will try, okay, Jigglypuff, INICT, okay, I have taken the chantings I have taken for other subjects. They are good for these subjects, okay. What I'll do is I will try to take remaining subjects for INICT in April, okay. March is packed. April, I will try to take some sessions for INICT, okay, fine. Now comes the question, what else do we also see, discuss or have, right? Okay, so expiration and inspiration. First, when you inspire, where the air going? It is going where? The air is going to the lung from the machine. So machine loses the air. So it shows negative. Am I clear now? When you expire, you are throwing air into the machine. So that's why it is going a increase in the value. So that's why this is inspiration curve. This is inspiration. And expiration will increase. And this is your what flow rate? PEFR. This is called as peak expiratory flow rate. This is the peak expiratory flow rate. Around 15, 10 to 15. 10 to 15 liter per second. Rather 5 to 15. 5 to 15 liter per second. Then as the air comes from smaller airway, speed will decrease. So this is your MEFR. This is your MEFR. That is mid expiratory flow rate. 3 to 5 liter per second. Okay, 3 to 5 liter per second. Fine. Yeah, thank you for all your compliments. Okay, in fact, I got very good score just by using my own chantings. Okay, clear. And I regret I should have completed all the chantings, all the subjects, all the topic. Then maybe I would have got 700 plus. Okay, so that would be a real achievement if I would have hit 700 mark. Okay, but I lost because of OBG, ortho and surgery. These three became my, Waterloo. I was not doing the subjects. I never prepared them properly. And that's why these questions, almost 50 questions I got wrong because of these 3-4 subjects. Okay, so that is a problem. So 150 I got right and 50. So you can guess my score. Okay, so this is the case MEFR. And what is the value of MEFR? 3 to 5. Okay, yeah, I gave the exam, okay, to get the questions. Okay, and this value is called as vital capacity. So this is one more question for us, vital capacity. So let's say if this is 0, this is 5, so we'll get vital capacity 0, 1, 2, 5 liter. So 5 liter. So it is vital capacity. So this is a normal pressure volume curve. Okay, now remember how to recall it. Remember it like this: a cap with a Okay, so triangle on the top and circle, semicircle at the bottom. This is the normal flow volume curve. Okay, how to remember? First is remember this as a phase. Okay, and a inspiring phase. Which phase? Inspiring phase. So remember, face of babies are always very inspiring. They're always smiling and they have a expectation mountain. So parents put a mountain of expectation and their face are always smiling. Face is like a circle. So face like a circle, inspiring face. And what is there on the top? Expectation mountain. So mountain is triangle shape there. Okay. So what expectation? Okay. What expectation? Okay. Okay. It is triangular shape. So it is triangular shape graph in this case. So triangular shape graph. Okay. Expectation mountain. Okay. Done. Then inspiring face. Okay. So what are inspiring face? It is a case. Okay. So face of a baby is inspiration. So now look at the graphs. What are the various shapes we will see, discuss or have? Okay. I'll just first make normal one. This is normal. This is normal. Now have a look. Look at this. What do you see here? What looks poor? What looks poor? What looks poor? Yes, it is the expiration which is normal. Inspiration is poor. So what is your diagnosis? What is your diagnosis? Inspiration poor. Is the intra, extra or what? Which obstruction? Guess and tell me. Yes. Tell me. Yes, it is variable extra thoracic obstruction. You are right. Then here, what is poor? What is poor? The inspiration is okay, expiration poor. So it's the VITO. Done now? And look at this one. It look like what? It look like lips saying you FO. So it look like some lips saying FO. FO means follow on or something. Okay, you know, FO. FO is fixed obstruction. So now you'll never forget, fixed obstruction look like lips saying you go and do FO. Okay, done now. So now everything is crystal clear. And if there is a narrow curve, this is RLD. Low VC will make a very narrow curve in RLD like this. So this is normal. This curve is RLD. This is normal. RLD. Are you clear? So this is RLD. So this is the RLD. So clear now? I will try to give ionized CT because I have to check my schedule, because actually we all prepare for NEET PG because that is our main target. Ionized CT is just an afterthought. Okay, I'll ask Rajat if he's also giving. I'll go with him. Dr. Rajat, he gave with me. Okay, now are you clear? So let's solve the question. So the answer, you can see in this graph, it is looking abnormal where? Yes, there's a poor expiration. So we are going for yes, COPD, which is VITO. It is not extra. Why? Extra will be having inspiration. fixed, both are affected. Restrictive will be narrow graph. So that's why it is not the graph. Answer is B. Okay. So I hope now it's clear. Now, question number 13. Again, it's a compliance curve. So question number compliance curve. Okay. See, point is na, when you people give the exam, you give with expectations. Okay. You have to get a good rank. And when I or me or Rajat or even Thamim sir, when we give the exam, we don't have any expectation. Why? Because even we get a very bad rank or very bad score, who cares? Okay, clear. You people will not judge us. Even if I get 100 marks, you will not say, oh sir, only 100. I say I only solved physiology question and I got 100. You will say, oh sir, very good. So that's why the level of achievement change. Are you clear? Like a young kid, even if he say a ABCD, you say wow, clap. Or if a Alzheimer patient say ABCD, again you clap. So we are like Alzheimer patient. Even knowing ABCD is a big achievement for us. So even getting 100 marks is a big achievement for faculties. But I want you people to do everything properly. Concepts were the main thing. What my observation was, every question, even if it's a recall fact-based question, it had some concept. Like physiology, all graphs were there, but they were concept-based. You cannot mug up. Like that facet diffusion question I'll show you, or the GFR graphs. So that's why concept is the case. Get the concept clear, exam would be clear for you. Okay. Now understand compliance. Compliance is delta V by delta P, and it is increased in emphysema, okay, then reduced in OLD, obstructive lung, reduced in RLD, single lungs, okay, and can be normal in OLD. But if they ask you what should be the answer, it is mostly increase because of air trapping or increase. But I will tell you, or increase due to air trapping. The air accumulate in the lungs, and because of air accumulation, volume increase. High volume cause more compliance. Okay. So one line summary: compliance is increase in emphysema, decrease in restrictive disease or single lung, or in fact all lung diseases except emphysema have poor compliance. One line summary: they have poor compliance. So this is your poor compliance in this case. Okay, so this is our which compliance? Poor compliance. So I hope is clear. So is it clear to all of you? Okay. Now, how do you check the compliance? So a formula I told you, pressure by volume. So I'll solve it in this graph. Do one thing, draw a straight line from the 10 point like this. I know it doesn't look straight, but okay. So now what we do is we calculate the compliance using this line. Okay. So first is, let's say normal one. At normal, this point, I'll change the color of the pen to, let's say, purple pen. Okay. So at this point, what is the volume? Let's say 5.5. So I take it 4.5. So 4.5 liter and pressure is 10. So we can write 4500 ml by 10. That will give me around 450 ml per centimeter H2. So 450 ml per centimeter H2O is the normal compliance. Now let's see the B1. B1 is around 220, let's say 2.5. So it's 2.5 by 10. That give you 250 ml per centimeter H2O. Okay, done. Then finally this graph here, it is around 7.5. So that make it 750 by 10, sorry, 750. So one line summary. In B, the compliance is reduced. The graph is shifted where? So it is low compliance, right shift. Right shift. So right shift is which compliance? It is your low compliance. So low compliance cause a what shift? It cause a right shift in the graph. Right shift. Okay. Okay. And left shift is basically high compliance. High compliance, right shift. So high compliance is our right shift always and always. Okay. So let's solve the question. They are asking where is the slope A. A is obviously high compliance. So high compliance is emphysema. Answer is C. Now in bronchitis, it can be normal or reduced. So what is the concept? It can be normal or can be increased or decreased, but it's mostly normal or increased. Then restrictive, it is decreased. Single lung, it is decreased. So best answer is C. C is the best answer. Okay, C. Then 45-year-old inspired. This is basically flow volume curve. This is basically nothing but a flow volume curve. This is expiration. This is inspiration. Are you clear? Videos coming from my end. Maybe some other issue. I hope it's clear. Okay, let's continue. So this is a flow volume curve, and let's check what does this give. Give vital capacity. Calculate. This is what, 5.5. This one, this is actually RV, residual volume. RV, residual volume. So this is vital capacity 5.5 from 1. So this is 4.5. C is the answer. Okay. C is the best answer. Okay. C. I'll upload the PDF to the group later. Don't worry. Okay. So this is 5.5 minus 1, 4.5. Okay. So I think it's clear. Okay. Question 14. I told you 14 is nothing but vital capacity. Is maximum inspiration followed by maximum expiration. So what is VC? VC is maximum inspiration followed by maximum expiration. Okay. Done. So here the person started inspiring. Here he started expiration. This is his PFR. This MEFR. I taught this graph already, if you remember. Remember this graph. Okay. Check it this. So I discussed that graph already. So here I discuss it. Remember? Vital capacity. And this is 5 liter. So that is the case. Okay. So what does the value it give you? It gives you the, okay, see, please contact the DBMCI, team coordinator or whatever team buddy for the PDF links. I will upload to them or the group, they can share. Okay, so this is the idea clear. So this is 5.5 and it is going till 1 liter. So that is why the vital capacity RV is 1 liter. You can see 1 liter is not coming out. It is only coming till. So what is the air not coming out? RV is not coming out. What comes out? VC not coming out. So RV is coming out? No, not coming out. That's why this is vital capacity. How much equal to 5.5 minus 1? That give you, yes, 4.5. So that give you 4.5. Are you clear now? So is the answer clear to you? Okay. Now we'll discuss question number, yes, 15, 16, 17. Let's start now. So copy with me and we will understand. First, what happens at high altitude? Again, this question was there in the exam. High altitude, there is decreased PO2, decreased oxygen, and this cause hypoxia. Hypoxia. Decrease PaO2. Now hypoxia causes what? It causes it causes two changes. It causes hyperventilation and also causes pulmonary vasoconstriction. So two changes are hypoxia and pulmonary vasoconstriction. Now what does pulmonary vasoconstriction do? So pulmonary, it can cause pulmonary hypertension, then also pulmonary edema, non-cardiogenic. Non-cardiogenic. And this pulmonary edema, which is non-cardio, is the most common cause of death in mountain sickness. Okay, and with the treatment we give, treatment here is steroids. For hypertension treatment, we can use ARB or nitrates. Okay, then hyperventilation cause what? It causes CO2 washout. CO2 washout cause two changes. What two changes? One, it causes respiratory alkalosis, and here the treatment is CA inhibitor, acetazolamide. In fact, it's the drug of choice for mountain sickness. So, for the drug of choice, so let's see the question. What is the problem? Hypoxia reason, fall in the oxygen level. Then what is the correction? Hyperventilation is the first. So the first correction, person start hyperventilating and they find dyspnea. They say, थोड़ा दिक्कत हो रहा है, होता ना Leh Ladakh. Some people go for the bike ride on Leh Ladakh and then they realize कि they made a mistake. So before they feel that mistake, they are, yes, having hypoxia. Okay. Then yes, acetazolamide is the drug of choice for what? Mountain sickness. Okay. And then also it causes apnea. Why apnea? Because high CO2 stimulate the respiration. Low CO2 will inhibit the respiration. So low CO2 inhibit our respiration. So what stimulate? What stimulate? Yes. So respiratory alkalosis, apnea is there. Okay. Yes. Now this apnea is not permanent. Again it causes, so it causes hypoxia because of apnea. Again hyperventilation. So what occurs? Person will start doing hyperventilation again. Okay, and this keep going on. Hyperventilation, apnea, hyperventilation, apnea, hyperapnea, hyper. This is called as your Stokes breathing. Stokes breathing. Are you clear? So what is Stokes? It is hyperventilation followed by apnea, again hyper, again this. So this was the exam question which is given here. This is your kind strokes breathing. Kind strokes breathing. Okay. Kind strokes. Okay. Now, what are the other breathings? Let me tell you that also. The answer of this question is kind strokes. It is kind strokes. Others. Biots is a irregular breathing. So irregular breathing with spells of apnea. Yes, carbon dioxide is causing the respiration to increase. So low carbon dioxide will cause apnea, that is stopping of respiration. Irregular breathing with spells of apnea. Biots. Like this. So it's irregular with spells of apnea. Apnea is there, okay? So which are apnea spells? These are all apneas. Okay. What is the example? Brainstem injury. Brain stem injury. So example is brainstem injury is there. So are you clear? So brainstem injury is the case. Okay, now comes the question. What is this Kussmaul? Here there is what? It is due to acidosis. Acidosis. Which one? Diabetic ketoacidosis. What happens? There is, yes, rapid breathing. I will explain 15. Don't worry. Rapid breathing with no or few apnea. Why? Because what happens is, okay, I will complete every question. Don't worry, okay? Don't worry, okay? So rapid breathing, we have done the biggest systems. What system? We have done the system of CVS and CNS. They are the largest system. Once they are over, time will be not taken much, okay? So few or no apnea, that is the concept, okay? So that is Kussmaul. So Kussmaul is the just rapid breathing without much apnea is called as Kussmaul. Reason, acidosis will keep stimulating the respiratory center, so you keep doing hyperventilation. Are you clear? So there will be no apnea in this case, okay? And paradoxical is reverse movement. It is seen in flail chest, okay? What happens here in paradoxical? There is inward chest movement in inspiration is called as paradoxical. So answer is C, is not D. That's the case, okay? Fine, okay. Now question number 15 is again from the high altitude. Let me discuss what is the funda. A person who live at high altitude, remember exercise is very important for acclimatization. Exercise help in acclimatization. So acclimatization, okay. Now what is the funda about that? First question, how? Exercise induce hypoxia and hypoxia then cause changes. First, stimulate respiration, then CVS. So stimulate respiration and cardiovascular system, which improve the circulation and also increase VEGF, EPO, etc. Now what is VEGF? It is vascular endothelial growth factor. So vascular endothelial growth factor is VEGF. VEGF. Okay. And what is EPO? Erythropoietin. EPO is erythropoietin. So EPO is erythropoietin. Okay. What does? It increase RBC and increase oxygen carrying capacity, which help you take more oxygen to the tissue, and that correct hypoxia. And it cause increase vessel formation, and once there is an increase in the vessel formation, it again cause improve circulation and make the body able to, yes, survive better even in low oxygen condition. Also there is what? Increase respiratory volume, increase lung volumes. So these changes are all part of what? Acclimatization. What are the thing? We need what here? We need the hypoxia to occur. But problem is, if there is a sudden acute hypoxia, it can cause respiratory sickness, mountain sickness. So that's why we need what? We need a chronic but low grade hypoxia. But remember, high demand can cause severe problem. But remember, for exercise, what case? Low load, low intensity to prevent excessive oxygen demand. Otherwise, high oxygen demand will be a problem. So we want to keep a low oxygen demand. So we need to keep a low oxygen demand. So that's why oxygen demand should be less. Okay. And what should be the duration? Less or more to allow alkaline. It takes months. You cannot do. So that's why they say like 1 week at base camp, then 2 weeks at the first camp. This is something like that. Okay. In mountain climbing, the rule you should not immediately ascend. We should. So that's why. And it takes months. Take months. So that's why soldiers who stay, they are first brought to the base camp and they are asked to, yes, exercise and increase duration for better time. So that's why decrease the load. Why? If there is high load, it will cause increased demand and that can cause the edema. So that's what the mnemonic here is. So mnemonic is decrease the workload but increase the duration is the right. Others will become wrong obviously in this case. Are you clear? Okay. So we'll take a break. We have done almost all the major questions. Okay. Clear? 16 till 16 we have done. 17 also if you want we can do. So we have done almost 20 questions in the initial 2 hours and then remaining 3 hours. Class is till 9:30. Okay. So we have 3 hours. We'll do the remaining 33 questions. So class is till 9:30. Okay. Then I'll go to airport for flight 11 o'clock. So 11:30. So we'll take a break 15 minutes. Break, yeah.